Welcome back in MedSynapse podcast. So today we'll glad to announce about our guest for this episode. So welcome Dr. Khalid. Dr. Khalid Ashahrani is a consultant of rheumatology. So Dr. Khalid, firstly, before unveiling any complexity related to gout, let me know more details about medical background for Dr. Khalid himself.
Okay, thank you, Diana. It's my pleasure to be here. My name is Dr. Khalid Ashahrani. I'm a consultant of internal medicine rheumatology. I got my medical degree from King Saud University. Then I pursued my internal medicine and rheumatology fellowship later. Then I got a short training fellowship in St. Thomas's in Guy's Hospital. Then I got my lupus fellowship, systemic lupus erythematosus from University of Toronto in Canada.
Great. So depending on this wide experience and strong medical background, so Dr. Khalid, today we will have a complexity of gout. So we will start and give some tips and tricks beyond all complexity related to gout. So let's start with, are there any advanced approaches that completing identifying urate crystals in joint fluids?
Okay, so when we're talking about gout, we're talking about something common, especially in the Arab countries, mainly in the Middle East, and the reason behind that is because of our dietary habits. So, if we're talking about the way to diagnose gout, many ways are available, but mainly we depend on the clinical. Let's say presentation of the patient. So if you have a patient at the clinic with the presentation of gout, you go back to the history, and then for sure you have to examine the patient, because gouty arthritis have some characteristics, features in the examination that might, like, let's say, let you depend on it just to diagnose the patient. But if we're talking about the gold standard of diagnosing patient with gout, we have to go to the joint aspiration by, let's say, skilled orthopedic or rheumatologist to get to the synovial fluid, and then you will examine it under the microscope. You will see the monosodium urate crystals. So this is the gold standard. But then you have other options like different imaging modules. If we're talking about, let's say, ultrasound, you can see the double contour sign in ultrasound. You can go to the dual energy CT as well. MRI might help you as well. So in general, like most of my patients, I diagnose them clinically, mainly. But if we are in doubt, like if the patient is presenting with long, let's say, term arthritis, it looks like gout, but then you have to rule out different other diagnoses, like, for example, septic arthritis, rheumatological diseases or autoimmune disease. So you have to aspirate the joint.
Great. So, Dr. Khalid, how do you identify the patient at higher risk of gout flares?
Okay, so as I said, it is common in our Arabic countries. Yes. Mainly patient with let's talk about the risk factors for those kind of patients. So mainly patient will present to you with a sedentary lifestyle. Patient is obese. Sometimes patient might present to you with like a habit of eating a lot of meats, or let's say puree-rich food. Patient with comorbidities like diabetes, hypertension. So these are like the risk factors that we see a lot of patients with gouty disease. Mainly the presentation is called Viagra, which is the inflammation of the MTP, MTP joint in the foot. So most of the patients, when they present to you, they will present with swollen first joint of the foot. It doesn't matter right or left, but at the end of the day, like, the main presentation usually affect the foot. And you might see it in other joints as well, like, let's say, knees, elbows, shoulder to a lesser extent, but it might present as well.
So great, Dr. Khalid. So Dr. Khalid, how do you utilize the risk scores to approach your maybe management approaches and tools?
Okay, so if we're talking about, let's say, scoring systems,
Yes.
we don't really have a lot, but like usually we do have some that we can use, although there are not a lot of let's say studies on them. Usually we have a scoring system that we use. Not a lot of rheumatologists use, but let's say some of them. And again, it goes back to the risk factor. So if the patient is a male patient, that is a risk factor. If the patient is having hypertension, that is a risk factor. If the patient is having, let's say, high uric acid level, more than 5.8 milligram per deciliter, that is a risk factor. If the patient is having previous history of arthritis, so we're talking about monoarthritis or arthritis that affects one joint, that is a risk factor as well. So this scoring system is using points. So for each of these items, it gives a point. So and the highest one among these is the let's say the uric acid level. So it gives around 3.5 points. So the scoring system is allowing you to go between 0 and 30. If the patient is having 8 or more as a scoring or as a score, so this patient is at high risk of having gout. But again, mainly these scoring system and let's say classification criteria are mainly used for research purposes rather than diagnosing your patients. So you don't see us use it a lot in our clinic.
Great. So, Dr. Khalid, what are the mainstay medications and the treatment options for gout?
Okay, so if we're talking about treatment, so we're talking about two approaches or two categories. The first one is the acute flares, and then the chronic or the maintenance. So if we're talking about acute treatment, let's go to the background. So the background of the gout disease is not an autoimmune process per se, it is an inflammatory process. So merely you have an inflammation in the joint, you have to treat it. It's not bacteria, it's not, let's say, fungal, it's not viral, it's not an autoimmune process. So if we have an inflammation, we have to give an anti-inflammatory medications. So in acute flares, usually if the patient is identified or diagnosed with having gout, then you have to treat the acute attack. So we do have a lot of options. Usually a lot of physician or rheumatologist or family medicine physician, they will start with having or putting the patients in anti-inflammatory like non-steroidals. Colchicine is another option. And cortisone or steroid can be used as well in some cases. I personally prefer to start the patient on non-steroidal, let's say naproxen, for example, or colchicine. If the patient is intolerant to those medications, or the patient is having, let's say, something prevent them from starting on non-steroidals, then I'll go to steroid. The beauty of a steroid is the fast effect. For example, for non-steroidals and the colchicine patient might take time to improve or get out of the acute attack. But with the steroid, usually you will see fast response within 2 to 3 days, and usually will not go beyond like 4 days. So I usually start the patient on, let's say, if the patient is intolerant to the non-steroidals and other options, so I'll go to for the patients having kidney problems, I'll go to steroids, let's say 30 to 40, depending on the patient's weight, and then for 3 to 4 days, and this will get rid of the acute attack. If we're talking about the chronic gout, so a lot of debates are there about starting the urate lowering therapy at the onset of the acute flare if the patient is not on them previously. I usually prefer, depending on the available data, to treat the acute flare, and then in 2 weeks, like 14 days, we will start the lowering therapy. And at the same time of starting the urate lowering therapy, I'll keep the patient on steroids or colchicine for let's say a week or two, and then I'll stop it and ask the patient to continue in the urate lowering therapy with follow-up, of course.
Great. So, Dr. Khalid, in this section, we will have a different question about ULT agents. So, Dr. Khalid, how do you choose or select the most appropriate ULT agent for your patients?
Okay, so as I said, it depends on the patient's, let's say, condition. Most of the patients were using the common medication, which is either allopurinol or febuxostat. So, if the patient is not having a cardiovascular risk, febuxostat can be used. But most of the patients are started on allopurinol. So you start the patient on, let's say, 100 milligram, and then you taper it up with time, let's say in a week, or depending on the uric acid level. But the xanthine oxidase inhibitors are mostly the mainstay treatment for those patients. We do have a lot of options, but I might give you a rough estimation of our patients in my clinic. Let's say 85 to 90% of my patients are either on allopurinol or febuxostat. Okay, so allopurinol is the mainstay of treatment. You start the patient, you start following the patient. If the patient is improving, that's great. 100 is enough. If not, if uric acid is still high, patient is having another attack, let's say in a close time, then you might upgrade the dose. You might go to 300. If the patient is intolerant to allopurinol, or the patient is having, let's say, contraindication to use that medication, you might go to febuxostat, given the fact that the patient is not having any cardiovascular system problems. Because there are some studies linked, which is, let's say, not strong studies, but the recommendations is not to start febuxostat in a patient with cardiovascular risk. Okay, we do have another options as well, like gluticase, herbicide, but these are, let's say, seldom used. I mean, I've never used it before, except I have one patient only in the gluticase, but that medication is an IV medication, and then if the patient failed all the options, let's say a patient is failing allopurinol, febuxostat, and the other options, then you might go for it. And as I said, it is an IV medication. It needs some preparation with it. Also, you have to start some other medications while using the gluticase. Like the patient is starting on that medication, you start the patient with methotrexate. You have to start the patient with folic acid as well. So it's a long process, and I hope we'll not go there. So most of my patients are like using allopurinol or febuxostat as, let's say, first line of treatment.
Perfect. So, Dr. Khalid, how do we approach managing patients with established tophi?
So, if we're talking about tophi, so tophi is like, let's say, long-term complication of untreated gout or neglecting gout. And like some of the patients might have tophi at the first presentation, although rare, but it might present. You might have a patient with that presentation. Tophi is a special condition, and you have to work on it in different way. So, for example, so if you have a patient with high uric acid, and patient is having an established diagnosis of gout, having the patient followed in your clinic and seeing the uric acid level every now and then is important. So the recommendation is to keep it, let's say, between 6.4 and 7 milligram per deciliter. But in patients with tophi, no, you have to go below 5. You have to make sure that it is going, the recommendation is to go below 5. That's the first thing. And then the other aspect is, if we're talking about colchicine. So most of the gout patients are using colchicine as one of the treatments that we use usually in patients with gout. Patients having tophi, I would recommend that you keep a patient on colchicine for at least 3 to 6 months, unless the patient is having contraindication or like a complication of this medication, which is, by the way, colchicine is one of the good medications as an anti-inflammatory. But then most of the patients would stop it because of the side effect, which is GI upset, diarrhea, as you know. But it is a great medication. And then some of the patients will need to go to a surgery. So if the tophi is big or causing a joint destruction, or let's say presenting in some cases that might affect the patient a lot, because some patient might have a tophi in the ear. Okay, so those patients you might refer them to a plastic surgeon, and then they will take care of it. But the problem with the tophi is the joint destruction mainly. So as I said, tophi is something. You don't see a lot, but if you see it, you have to work with it or deal with it with special ways.
Great. So Dr. Khalid, are there any exciting advancement on the horizon?
Okay, that is a great question. Like rheumatology, like our advancements in the treatment in all of the rheumatological disease, we do have more than 100 diseases at least. So we're going slowly. Like for example, for lupus disease, we don't have a lot of options since 1995, and then lately we did have one or two new medications as well as the vasculitis. But in gout, it's almost the same, more or less. As I said to my patients all the time, okay, treatment will help, but modification of the lifestyle is very, very important. Because if you concentrate in one approach, you will not go to the ideal situation. So I will support you until the patients will do this sentence. I will support you, but please support me. So at the end of the day, we will reach to the ideal situation together. But until now, it's almost more or less the same choices of treatment. Nothing new has been published recently about the advancement and treatment of gout in a patient, let's say chronic gout patients.
Great. This section, Dr. Khalid, we want to ask about maybe patient awareness or how do you handle patients to accept gout and deal with it. So, Dr. Khalid, how do you engage patients in treatment discussion for gout?
So the first thing to do usually in your clinic is to explain to the patient what is gout, because it's very important for the patient to accept and understand the disease in order to control it. So I usually sit with the patient. I explain to the patient that usually this is the disease. It is an inflammatory process. You have to control the uric acid level. You have to control your life, like lifestyle modification, do more exercise, decrease the weight, pay attention to your food, the consumption of purine-rich diet, avoid any, let's say, medication that might, if possible, of course, that might increase the uric acid, because as you know, we do have some medication that might increase the uric acid level, and then it might affect the uric acid level in the body, and then it will cause acute flares. So, as I said, usually explain to the patient the condition, explain to the patient what needs to be done in terms of lifestyle modification and the whole process, and then start the discussion of the treatment in two approaches: the acute flares and then chronic. Sadly, most of the patients are stopping the maintenance therapy, like in the follow-ups later. Like for example, 3 to 6 months, you'll see the patient stopping the medication, and when you ask them, the patient will respond that I'm great, like it's gone. And then 3 months later, the patient will come to you with acute flare, and that is the thing that we don't want, because every acute flare will cause a joint destruction. So I'm concentrating most of the time on explaining to the patient what is the disease itself and what should be done in order not to have an acute flare.
Great. So Dr. Khalid, gout often coexists with the other comorbidities. So how do you ensure integrated maybe management strategy for these cases?
So usually patients with gout might present to you with a whole package. Saying that, meaning that patients with gout usually might present with other comorbidities, like for example hypertension, diabetes, as we said earlier, high cholesterol level, obesity, or high BMI, having a medication that might increase the uric acid level in your body, like for example, patient on diuretics or thiazide. This is a risk factor of having high uric acid. So, like treating gout or controlling gout is not controlling. It's not about controlling the uric acid level only. It's controlling the whole comorbidities. Because, and this is an information that is very important. Like for example, I have some patients in my clinic with very high uric acid level, like let's say 13, 14, and they don't have any gouty attacks, no acute flares, nothing, and they come to my clinic for general checkup, and then we found the uric acid level high, and at that point, I explained to the patient, although you don't have any acute flares, but you are at high risk of having an acute flare. You are at risk of having urolithiasis or renal stones. Some studies have linked the high uric acid level with cardiovascular system problems. So having high grade or high level of uric acid is not great for you, even if you don't have an acute flare. So controlling the gout and controlling the other comorbidities, especially the obesity. I've seen like a lot of improvement in patients who lost weight, like in terms of controlling the current attacks. So it is a holistic approach. You cannot concentrate in one thing and forget about the others. You have to concentrate on the gout and the other comorbidities along with it.
Great. And finally, Dr. Khalid, I need to ask about how do you monitor and maybe address treatment strategies for chronic patients, chronic gout patients, to prevent all long-term complications that can be happened?
Okay. As I said earlier, unfortunately, most of the patients will stop the treatment. And unfortunately, there is no strong recommendation about how long the patient should stay on the urate lowering therapy. Personally, it depends on the patient's follow-ups, and if the patient is, like, let's say, following with you, patient is taking care of themselves, like in terms of food, lifestyle modification.
Yes.
Like let's say patient is taking the medications on regular basis, not stopping them. But in general, usually those patients, as I said earlier, if you explain to them the complexity of the disease and the patient understand exactly what is gout and what should be done, the patient will improve with time. I cannot say to the patient that you have to stay in this treatment for a long time or for lifelong, because it's not true. If you do not stop the medication yourself, the patient will stop them. Okay, but understanding the disease is important, and explaining to the patient the complications that might happen if you do not take care of yourself is very important in the long term, in the long run. As I said, the complication that might happen if you do not take care of yourself is like having recurrent acute attack, and that will cause joint destruction with time, and that thing that you don't need, because male patient, young, and then you have joint destruction, that is so debilitating. I mean, you are at the beginning of your life, you don't need these complications at the young patient. The other thing which I see, since this is the final question, I have to mention this. There is like something I see a lot of in my clinic, which is a young female patient on urate lowering therapy. And when I asked them why, they said, well, my physician started these medications for me. This is should not be happening, because in a female patient, there is a protective way to prevent them from having gout yet, which is the estrogen. Okay. So this is, I'm not going to say a wrong practice, but if the patient does not need these medications, please do not start the patient with urate lowering, especially if we're talking about young female. Okay, after menopause, the chances of having gout in female patients might be the same as the male patient, but if the patient is still having their periods, please do not start the urate lowering therapy unless it is really indicated. And that is something I see a lot. I mean, in my clinic, I might say like roughly, I would have 2 to 3 female young patients in urate lowering therapy. Unfortunately, and I need to stop them at the clinic, but this is a message that should be delivered to the other doctors. Usually, like let's say 80 to 90% of your patients with gout will be young male, not female patients.
Great. Thank you so much. And finally, I want to thank you so much, Dr. Khalid Ashahrani, for sharing your experience with us on MedSynapse platform as well. And hopefully, it will be a just start engine to continue our series and adventure in rheumatology on your guidance. Thank you so much, Dr. Khalid.
You are welcome. I would like to thank you also, Diana, for letting me here. Present here, and I hope that everyone who's listening to us or seeing us will learn at least something today. Thank you so much.
Thank you so much, and really it will be just to start the engine. Thank you so much, Dr. Khalid, and hope to see you in the most successful situation. Thank you.